Hello, thank you for watching our presentation, and our PICO question is, in children with acute otitis media, are antibiotics more effective than placebo in reducing duration of illness in clinical course? This is our table of contents. We have the PICO question, the rationale, the research finding and policies, and our summary and answer to the PICO question.
Acute otitis media is the leading cause of antibiotic prescriptions in children worldwide. Approximately 80% of all children will experience at least one episode of acute otitis media, with 1/3 of these children experiencing 6 or more episodes by the age of 7. This may lead to repetitive antibiotic use, and depending on the family or child's situation, they may visit different healthcare providers, which leads to an increased likelihood of getting different prescriptions for different antibiotics. For example, the most common treatment is amoxicillin clavulanate, but other treatments include azithromycin, clarithromycin, and for children with penicillin allergies, cefdinir, cepodoxime, or cefuroxime. Recurring episodes of acute otitis media being continuously treated with antibiotics further increases the chances of creating antibiotic resistance.
We chose to address this issue because we want to study the efficacy of antibiotic use versus placebos in managing acute otitis media. This is because we want to determine whether antibiotic use is truly essential, especially when this infection is likely to resolve itself. We also aim to determine if medical interventions are truly necessary and cost-effective, especially when observation and supportive care like pain management, good nutrition, and adequate hydration may possibly lead to the same outcomes. In addressing concerns and controversies, one of the primary controversies revolves around the practicality of prescribing antibiotics. Because in general, doctors, they need to consider socioeconomic factors and healthcare disadvantages of their patients. There's also a lot of differences between lower income countries and higher income countries. For example, in lower income regions, families often face significant financial disadvantages, and they may lack access to healthcare services in general. So when a child does develop AOM, and if they do end up going to the doctor for this ear infection, they're most likely going to want to get the prescription for antibiotics rather than risking the uncertainty of watchful waiting, because visiting a doctor is already a luxury to them. So this choice is perceived as a more cost-effective option for them because immediate treatment helps avoid potential complications, hospital visits, and further financial strain associated with the untreated infection. Also, there's a lot of socioeconomic factors that doctors need to consider, such as poverty, malnutrition, overcrowded living conditions, because these can exacerbate the spread of infectious diseases and increase the severity of the illness. So often doctors in these situations, they're just going to end up prescribing the antibiotics because the risk of this child's infection getting worse at home is way too high, because maybe the child doesn't even have good nutrition at home, or maybe they don't practice good hygiene. So they're better off sending this child home with some prescription of antibiotics. There also may be a perception in lower income areas that doctors are suggesting pain medication and watchful waiting as a means to exploit them financially. There's a distrust in the healthcare system, which may stem from lack of access to comprehensive health education and resources, and it leads to limited awareness about the appropriate management of acute otitis media. Families in lower income regions may view recommendations for watchful waiting. They may see it as a suspicion, and they may fear that doctors are motivated by financial gain rather than genuine concern for their well-being. Like, for example, they might think that the doctor is just recommending pain management and watchful waiting because they want to make money off of this family, because they're going to have to keep coming back for further care or anything they need for the child's ear infection. And if we compare all these factors to higher income countries, in higher income regions, families, they typically have better access to healthcare services. If you think about it, there's regular checkups, there's urgent care, there's the ER, there's even telehealth. So this means that they can easily seek medical advice and follow-up care if they need to, making observation or watchful waiting a good option for acute otitis media treatment. Also, families in higher income countries, they are often well informed about the natural progression of AOM and the potential advantages of watchful waiting. They often take proactive steps to educate themselves, they would use online resources like Google or other search engines to learn about the typical course of AOM. This knowledge empowers them to consider watchful waiting as a better option, especially for mild cases. And they know that if symptoms persist or worsen, doctors are readily accessible to them. Also, in higher income countries, there's often a strong sense of trust in doctors. So if families do decide to seek immediate medical attention for a child's ear infection, they're more likely to follow the advice of the doctor, which may include recommendations for pain management, good nutrition, and hygiene practices. This trust is combined with the understanding that doctors are easily accessible to them, so it gives them confidence in the decision-making process and the chosen course of action for the child's AOM.
We will now move on to our research findings. The first study conducted was done to assess the efficacy of antimicrobial treatment for acute otitis media when strict diagnostic criteria are used and the antimicrobial coverage and dosage of the active treatment are adequate. This was done through a randomized, double-blind, placebo-controlled study of the efficacy of antimicrobial therapy in the age group with the highest incidence of acute otitis media. Patients were randomly assigned to receive amoxicillin or the placebo for 7 days. The placebo was similar to the active treatment in appearance and taste. Results showed that treatment failure occurred in 18.6% of the children who received amoxicillin, as compared with 44.9% of the children who received the placebo. Overall, amoxicillin reduced the progression to treatment failure by 62% and the need for rescue treatment by 81%. In conclusion, our study provides evidence that in children 6 to 35 months of age, the treatment of acute otitis media with an antimicrobial agent that gives adequate coverage, such as amoxicillin, is beneficial. The second study conducted was done to assess the efficacy of antibiotics and placebos versus amoxicillin in treating acute otitis media or its symptoms in children 6 months to 12 years old. This was done through a systematic review of random control trials from the PubMed and Web of Science databases. Results showed the percentage of effective treatment of azithromycin versus amoxicillin was 91.6% versus 73.7%. Cefdinir versus amoxicillin was 71.0% versus 86.5%. Gadaflaxone was 81.2% versus 82.0%, and the placebo was 30% versus 61.0%. In conclusion, these trials of amoxicillin versus these alternative treatments do not have a statistically significant difference, and therefore amoxicillin remains the first choice treatment for acute otitis media. The third study was conducted to compare the efficacy and safety of azithromycin and amoxicillin for the treatment of otitis media in children. This was done through a systematic review and meta-analysis of randomized clinical trials from PubMed, Cochrane Library, and Google Scholar databases, comparing azithromycin and amoxicillin in treatment of acute otitis media in children. Results showed there was no statistically significant difference in azithromycin versus amoxicillin treatment in clinical and bacteriological efficacy. However, adverse side effects such as diarrhea, vomiting, nausea, abdominal pain, and loose stools had a statistically significant difference in favor of amoxicillin having greater incidence of adverse side effects. In conclusion, azithromycin is comparable in efficacy to amoxicillin and is considered safer and more tolerable by children. The fourth study conducted was done to clarify what extent children with acute otitis media benefit from antibiotics. This was done through a systematic literature search comparing antibiotics to placebo in patients with AOM. 5 of 6 studies employed amoxicillin and 1 used penicillin. The duration of treatment varied between 7 to 10 days for amoxicillin, 5 days for penicillin, and supportive care with acetaminophen and ibuprofen. Results showed that pain in the placebo-controlled studies was significantly reduced in children treated with antibiotics at 24 hours and at 10 to 12 days. No significant difference was found at 2 to 3 days and 4 to 7 days. Immediate antibiotics versus observation showed significantly reduced pain at 3 to 7 days. Antibiotics significantly reduced the risk of contralateral otitis media and tympanic membrane perforation compared with placebo. In conclusion, children under the age of 2 years with bilateral AOM and children with otorrhea seem to benefit more from antibiotics. The fifth study was conducted to compare the two approaches of the treatment of non-severe acute otitis media, antibiotic treatment, and watching and waiting for spontaneous resolution of the infection. This was done through a randomized controlled trial. Key variables included intervention versus control, age of participants, diagnosis of AOM, signs and symptoms of adverse drug reaction, recovery from AOM, recurrence of AOM, and middle ear effusion. Results showed that AOM recovery was significantly different in the two groups, 73% for antibiotics, 44% for watchful waiting with supportive care. The AOM reoccurrence between 1 and 3 months was more frequent in the watchful waiting group. The AOM and middle ear effusion recurrence between 1 and 3 months was more frequent in the control group. In conclusion, the study found that 73% of the patients in the antibiotic-treated group experienced AOM recovery, whereas only 44% of the patients in the watchful waiting group recovered. The sixth study was conducted to evaluate the effect of antibiotics on pain associated with acute otitis media. This was done through a systematic review of randomized control trials. Key variables include the use of antibiotics versus placebo or expectant observation in children with AOM. The primary outcomes assessed are pain at various time points and adverse effects likely related to the antibiotic use. Results showed that severe complications were rare, and the study suggests that serious complications do not differ between children treated with either antibiotics or placebo. Antibiotics did not reduce the number of children with late AOM recurrences versus placebo. However, antibiotics did slightly reduce the number of children with perforations. In conclusion, antibiotics have a limited efficacy in reducing symptoms in children with AOM and may result in adverse effects such as diarrhea and a rash. For most children with mild AOM in high-income countries, a watchful waiting approach with adequate pain management seems justified.
So going back to our PICO question, in children with acute otitis media, are antibiotics more effective than placebo in reducing duration of illness in clinical course? Well, generally, the answer is yes, because based on the provided study findings, antibiotics such as amoxicillin and azithromycin, they were more effective in reducing the duration of illness. For example, like study number 1 and study number 5, they both showed that antibiotics like amoxicillin, it was more effective in reducing treatment failure and the need for rescue treatment compared to placebo. Study number 2 and study number 3 both showed that antibiotics were more effective in managing AOM, but they did increase the chances of adverse effects like diarrhea, abdominal pain, and loose stools, but they were still effective. And then study number 4, it revealed that antibiotics provided significant pain relief and reduced the risk of complications such as contralateral otitis media and perforation. But also, it's really important to think about how so much just goes into this. Like study number 6, it revealed that watchful waiting only seemed beneficial in higher income regions. The study settings and populations had a lot of differences. If we go back to the rationale and we think about the variability in study settings and populations, some studies were conducted in higher income countries, while others were conducted in lower income countries. This variation in study settings, it may introduce a lot of differences like access to healthcare practices, antibiotic prescribing patterns, socioeconomic status, the prevalence of antibiotic resistance itself. There's just so many differences. And we think that further research should be more focused on symptom management and the prevention of recurring episodes of acute otitis media to decrease the risk of antibiotic resistance. And here are our references, and thank you for watching our presentation. Have a good day.